next, we will have John Chu, who is an associate professor in the Harvard University Medical School and director of the Program for Clinical Economics and Policy. I'm going to let Dee switch us over to the right slides.
Say okay.
I keep thinking I should do this, but no.
No, that's what y'all are paying me for. That's why I'm here.
Right. We're creating jobs by not being able to do things.
It's a job security. We talk about this all.
Specialization is a very good thing, especially when it comes to messing up the technology.
All right, John, take it away. You can go ahead and share.
Okay. Let's see.
That's my side job. I'm a voiceover person.
I was gonna say it's
Call me.
it's the
Thank you.
Vanna White, you know, like.
Oh, yeah, probably should make sure y'all can see what's going on as well. Zoom room.
Can you guys see the slides?
There. Thank you, John. Now we can see your slides.
Yes.
All right, great. All right. Thank you. It's a pleasure to be here and talk to everyone again. It's a shame not to be there in person, but nevertheless, it's wonderful to see everyone. The title of this talk is Increases in Cardiac Mortality Between 2020 and 2024, Deadly Aftershocks. And first, I want to acknowledge my collaborators, as well as our funding from NIH through the UO1 mechanism. So, as we've heard in many talks during the past day and a half, there have been a lot of different health system shocks starting in 2020. And there were obviously some sharp increases in mortality starting in 2020 with the COVID-19 pandemic. But there have also been numerous subsequent policy changes, as well as other behavioral changes. And these have really resulted in a number of dramatic shifts in medical care use. Cardiac emergencies is one area which is an attractive sort of sentinel condition, in the sense that we're able to capture almost all the very serious cases because in many of these situations, people need treatment, or the lack of treatment can be often fatal. And so individuals will show up at some point in the system, and there's a reasonably decent ascertainment about what happens. Time is also really critical. And so anything that impacts when people show up, how long they wait, et cetera, can be really important. And there's also a fairly substantial evidence base on treatment efficacy. We know probably more in this area than we do in almost any other condition within medicine. And there are a number of reasonably good trials that have looked at various procedures, medications, et cetera. And that provides us with a fairly strong evidence base with which to examine how some of these shocks might be impacting care use as well as outcomes. So in 2020, there were a number of interesting and sort of disturbing reports that there were these large reductions in emergency department visits. And these were sort of occurring as many places were facing large outbreaks, but even in places that had not yet necessarily faced an outbreak, there were changes that were happening within the local healthcare systems. And there were reports that EDs were, ED use was dropping as much as 20–30% in many different areas. And ED use can be highly varied. Sometimes people use care in the ED as a mechanism as a substitute for primary care. And then obviously other times the care in the emergency department is really truly emergent, where time is of the essence. With acute myocardial infarction, AMIs, this is a good example, an area where most of this care is emergent, meaning that the care is really essential to happen really soon. And there were these observations and several published studies that suggested that the reduction in ED visits was quite large. In fact, a meta-analysis found somewhere between a 20 to 34% reduction in multiple countries around the world. And this was, fairly consistent. It didn't matter which country it was. It was just these large changes that were happening in early 2020. Other studies have found concurrent reductions in cardiac procedures during this time, and others suggested that there was there are various hypotheses that were posed at the time, like, well, perhaps the decrease in stress may have reduced the risk factors, but this would be potentially one of the largest potential changes and a tremendous impact for stress reduction. So there's some part of this story that didn't quite add up. Other reports suggested that there were reductions in inpatient cardiac mortality, and one of the big challenges that we've all discussed in various presentations over the last day is that we have these ongoing concerns about data quality, particularly during periods of where things were much more dynamic. And during the early parts of 2020, that was certainly a time period where things were rather dynamic and rather chaotic. A lot of these early reports came from hospital data. And so the finding that, well, fewer people are showing up at the ED, that's something you can observe in hospital data, and that what's happening in the hospital. But it sort of left this question like, well, what is exactly happening? And is it in fact that there are fewer patients who are having cardiac problems and exacerbations of their disease, or was there something else going on and we're not able to track those individuals? So we did a relatively simple study where we wanted to examine the population level changes in deaths related to cardiac emergencies, things like AMI, various arrhythmias, et cetera, and with real emphasis on changes starting in 2020. And we really wanted to compare the expected and actual monthly cardiac mortality rates in 2020 and all the way through 2024. We use state death certificate data, which gives us information about cause of death. It also gives us information about location of death. Specifically, it has information about whether the death occurred at home, in long-term care facilities, in the outpatient setting or emergency department setting, whether it was an inpatient death or it was other unknown. And we combine this with American Community Survey data to get population denominator estimates. And we focused on all Massachusetts decedents between 2014 and 2020, in middle of 2024. We've since extended to the end of 2024. What we wanted to do was first come up with a way of predicting mortality so we can get an expected rate. And we ended up using the negative binomial regression model because over dispersion. We essentially were predicting monthly deaths in each month. And really using data between 2014 and 2019 to get a baseline. And then we would use that to calculate the expected, as if the patterns between 2014 and 2019 continued from 2020 and on. And that was our expected rate. And then we compare that with the actual outcomes. And again, observed versus expected monthly rates per 100,000. We also looked at total deaths as well as deaths stratified by location, and we standardized by age and sex. This is the final model. I won't go through these details. And again, we also assessed the performance of this particular approach, and it performed quite well. I won't go into the details of this. These are the characteristics of our decedents. Overall, there was 128,000 individuals who died over this time period. The median age was 76, and you can see the age distribution. There is obviously, as one would expect, a monotonic increase as age group increases. The percent represented in this decedent population increases. And there's slightly more females than males, but the difference is fairly small. This is the race ethnicity distribution, which broadly corresponds to that of Massachusetts. There's also a lot of rich data within death certificates, including education information, and you can see the distribution here. There's also information about marital status, and again, you can see the overall estimates, the distribution, as well as the distribution among those who died with a cardiac death versus a non-cardiac death. And then we also looked at some seasonal infectious diseases, for example, whether they had COVID and whether they had influenza or some other form of pneumonia. So this is a look at all-cause mortality in Massachusetts, and this is from January 2014, and these are monthly estimates all the way through the end of July 2024. And basically what you can see in the early years between 2014 2019 is there's this sort of strong seasonal pattern where there are higher levels sort of late in the year during winter months, and then it sort of plateaus or naders in the summer. And then in 2020, we see this very large spike, as expected. And the sort of the height of this spike continues to be elevated in 2021, and then it sort of gradually goes away. When we look at monthly cardiac mortality, what we did again is we modeled the expected mortality, and you can see in the first half of the slide on the left-hand side, the 2014 and 2019, the expected, which is the dotted blue line, tracks fairly closely to the observed, which is the solid red line. And then starting in 2020, we start to see these deviations where the observed spikes up quite high, whereas the expected, as if the 2014 through 2019 pattern had continued, is sort of very steady along with the dotted blue line, and we see these large spikes that were present in 2020, in 2021. We see that in 2022. We even see that in 2023. When we look at this annually, we see elevated annual increases from 2020 all the way through 2023 and potentially into 2024 as well. So in other words, there were many more cardiac deaths that occurred within the state starting in 2020, and there continue to be elevated cardiac deaths in each year subsequently. Now, here's a look at the deaths that occurred within long-term care facilities. As you can see, in the period before 2020, the 2014 and 2019 period, the observed versus expected are tracked fairly closely, and there's a slight downward trend. Suddenly in 2020, there's a large spike, as we all expected to see, and then it largely goes away, and this downward trend continues. When we look at inpatient cardiac mortality, and again, there are a couple of these published studies suggest that inpatient mortality was unchanged or may have dropped. But this is from, these were from a few hospitals that had published their data. This is from all the hospitals within the state. And what we see is that, again, between 2014 and 2019, observed and expected are fairly comparable. And then starting in 2020, we see these deviations, and we see elevated monthly rates of inpatient cardiac mortality in 2020, 2021, 2022, 2023. Finally, when we look at cardiac mortality at home, we see a very similar pattern as what we've seen in the earlier ones, but again, a very sharp deviation starting in 2020. Again, between 2014 and 2019, observed and expected are fairly similar. Then suddenly in 2020, the number of the observed rate increases substantially, and it's much higher than the expected. and it's elevated in 2020, 2021, 2022, and even into a little bit of parts of 2023. So there are a couple of limitations to this particular analysis. This is a single state. And so the patterns, this was a state that was hit earlier than much of the country. And at the same time, it also has a slightly different healthcare system and a slightly different population than other states in the country. There always is a concern about misclassification of cause of death. But during the pandemic, and during periods where things are more chaotic, the risk of misclassification is potentially higher during that time period. And then I think one of the issues is with the data that we have right now, or at least the data we're showing, we don't really have the ability to differentiate between potential biological versus non-biological pathways. So just a few concluding points. Again, we started off with this as there's sort of something that was didn't quite seem to make much sense in the published literature, which suggested that AMI rates and other cardiac emergency rates were really dropping substantially in early 2020, and there didn't seem to be any plausible mechanism that would explain the magnitude of that change. And what we find is when we look at things on the population level, that we are finding actual increases in cardiac mortality. And these increases are persistent. They last over several years. They reflect shifts in location. There were more deaths at home than there were in medical facilities. And we're also seeing these exaggerated seasonal patterns. These, again, we're only using death certificate data here, but it does raise a number of interesting questions. There are potentially plausible biological pathways. Starting in 2020, not only was there the exposure to a new coronavirus, but there were also we've also experienced in subsequent years a fairly substantial disease burden with respect to other respiratory illnesses, and there definitely have always been at least a correlation between the frequency of those conditions and cardiac concerns. And then there are a number of non-biological pathways that are of concern. Certainly the number of individuals who are staying at home and not coming in for care at all is always worrisome. In many parts of the country, there have been workforce shortages. There's been backlogs in hospitals where hospitals are full. That's also extended into the EDs where there's crowding in EDs. There have been shifts in terms of how people are using care all the way through. So in a lot of our studies, we always assume if all else is held equal, and I think this is and I think the one way to summarize this is all else does not appear to be held equal. So with that, I will stop and take questions.